Good morning, everybody. Very good to see. I can see people are still joining, but it is 12 noon Geneva time, so I think we'll get started. Just to note, everybody, that the meeting is being recorded, and of course that recording will be available on the Global Shelter website afterwards. We will get started now, and please do interact and share your thoughts and questions and any relevant resources via the Teams chat as the meeting carries on. To introduce myself, I'm Sue Webb from the Centre for Development and Emergency Practice at Oxford Brookes University. And this session, as you know, is on shelter and health. And over the past Thank you. So over the last year, the shelter and settlements sector has made progress in better understanding the connections between shelter and health, including mental health. There's no doubt, sadly, that the COVID pandemic and the climate emergency are making some of the connections between shelter and health and mental health all too obvious. But people living in humanitarian crisis settings often have limited opportunities to improve their own living environments. Humanitarian actors are learning how to support physical and mental well-being through their programming, through connecting with other sectors, and through understanding how affected populations want to upgrade their own environments. Today's thematic session will explore further how shelter and health interact and discuss plans to develop our growing understanding into operational guidance, ideally with cross-cluster collaboration amongst the shelter and settlements, health, WASH clusters, and new connections with mental health and psychosocial support colleagues. This session will consist of two sections. I will start with an update on developing research on shelter and health over the last year, including an update of a recent shelter and mental health learning event. The remaining hour will take the form of a panel discussion, which will be facilitated by Ella, and you can see on the screen the panelists, the names and affiliations of panelists and speakers today, and there's more information on those speakers on the Global Shelter Cluster meeting agenda page. So if we move on to the next slide, much of the work on shelter and health over the last year has been instigated by the GCRF Self-Recovery Project, which is related closely to the Promoting Safer Building Working Group. You may have seen the working group update yesterday. The main theme of the research project is self-recovery, and one of its work streams is to understand better the wider impacts of shelter, including health. We'll put the link of the project website in the chat shortly. As many of you know, CARE and SENDEP, joint leaders of the self-recovery project, hosted the first Shelter and Health Learning Day in May 2020, which seems rather a long time ago now. And that followed earlier initiatives by various individuals and organisations. We needed to see what the humanitarian sector should apply from what is already known about the many connections between housing and health. Public health and development actors, of course, have been acting on this knowledge for decades. Following last year's Learning Day, we published a report we called Healthier Homes in Humanitarian Settings. You can see an image on the screen. And that incorporates summaries of the presentations made last year, as well as background knowledge about shelter, housing and health. We've continued to track the progress of the recommendations in that report. You may not be able to read them all on the screen, but the summary recommendations are there. And you can, of course, download the whole report on the chat and also via the self-recovery website. So today we're going to be pushing forward on some of these recommendations, such as exploring the potential for an intercluster working group with a focus on shelter, health and wellbeing. Also the importance of including local health issues in assessments, the need for a common understanding of mental health, and the need to generate evidence of the beneficial impacts that adequate shelter can have on physical and mental health. So self-recovery project partners are already acting on some of the recommendations made last year. In Malawi, for example, Crater has added health questions to its local context analysis methodology. And it's also added relevant health information on their new shelter response profile on Malawi that they've shared yesterday. CRS Malawi has for some time been working with local public health and WASH actors in their flood response programs in southern Malawi. In fact, Dinah Conde and Madalitso Jerry contributed a case study to a chapter we've written on the roadmap for research, which I'll be referring to a little later. Sadly, Dinah and Madalitso couldn't join us today because they're in the field doing the work that I'm just going to mention. Their shelter programming in Malawi routinely incorporates healthy home features. CRS works with communities and local artisans and their reconstructed homes include wire mesh and window openings, obviously to try to combat malaria. They train artisans, as you can see in the photo, of including a damp-proof membrane between the foundations and the walls to try to reduce damp. They are trying to make larger window openings to improve light and reduce problems with damp and mold inside the houses. And they are recommending minimum distances from pit latrines to shelters and kitchens. So they are already doing that work. And although they are making real progress, CRS Malawi and their local partner CARD also note ongoing challenges in developing shelter solutions that really do address all health issues. They note that it's hard to combat overcrowding, also dealing with polluting cooking fuel and smoke inside houses, also shared living space with animals with the consequent problems with trachoma, for example, and also dealing with the increasing problem of excess heat. So CRS are currently embarking on the challenge of evidencing their impacts and are designing research to measure and evaluate health outcomes of their previous shelter responses. CRS plans to disseminate the lessons learned through the Malawi Shelter Cluster's technical working group on promoting safer building practices. And that technical working group is convened by Cecilia, who's going to be joining the panel later on today. So there may be some questions for her. Perhaps we, as a sector, need to reflect on why so few shelter projects currently do manage to use this sort of environmental health lens in their programming. Dinah, who works in shelter in the CRS's Homes and Communities programming, actually has a public health background. And I think that's been quite instrumental in her driving forward those ideas within Malawi. Perhaps more shelter practitioners need to be trained to be able to include health objectives in their programming. We also note and look forward to an open session next Thursday on integrated WASH and shelter programming, including tools and frameworks that will generate evidence. And I'm hoping that we'll hear more about that later on this morning from Monica, who is the Global Welsh Cluster Lead, and she's going to be joining the panel as well. So the need for evidence brings me on to the need for further research. As I just mentioned, I worked with Emma Winstein Sheffield and Bill Flynn from CARE, also with George Foden from BRE and two other co-authors, Javier Sidon and Eric Solera. And we together wrote a chapter in Interactions publication Roadmap for Research, which is actually being launched later today, as I'm sure many of you know. The chapter we've written is called Adopting an Environmental Health Lens in Practice, as it suggests that the field of environmental health lends a useful approach to considering all the threats to health posed by people's living environments, including their homes and their settlements. Our chapter outlines many research gaps that remain on the impacts of shelter programming on health. Do read it, and please do think about how your organisations can contribute to these evidence gaps. Emma and I have also written an opinion piece about healthy homes for the upcoming Shelter Projects edition. Until now, and you can see the previous editions on the screen, health outcomes have rarely been reported in Shelter Projects case studies. In the 2019-20 edition, just soon to be published, there have been much more of an effort to encourage case studies authors to reflect on health outcomes of their projects. And health has now been included as a specific theme in conducting the meta-analysis of project strengths and weaknesses. So that's another piece of progress, because of course those shelter projects are such a useful resource globally. We're also pleased to announce that CARE has been awarded BHA funds to support the cluster's strategic advisory group with research on shelter and health beyond the end of this current self-recovery GCRF project. The first significant activity linked to that funding and the ongoing GCRF funding has been to pick up from last year's recommendation that shelter practitioners develop their understanding of mental health. As I said last year, shelter practitioners expressed a lack of confidence really regarding incorporating mental health into their shelter activities. Identified gaps included the lack of a common understanding of mental health terminology, inclusion of people with psychosocial disabilities, and the ways in which people's physical health affects mental health and vice versa. Participants expressed the need for greater knowledge about the parameters of mental health and psychosocial support, and the need for a deeper look at the various ways that humanitarian shelter practices intersect with mental health and well-being of affected populations. There were really lots of gaps in capacity to recognise, measure, or really even talk about indicators of mental health competently. So there was a collaborative process to develop the agenda for the Shelter and Mental Health learning event, and we held over 2 half-day sessions. And people from many organisations, including CARE, CRS, NRC, IOM, and many others, contributed to a growing list of ideas that we wanted to tackle, and we grouped them into 3 main themes. And those themes, of course, intersect, and they're represented on the diagram on the screen, those 3 big circles representing those 3 main themes. And all those themes and their intersections sit within the overall aim for human development. And also, we're very conscious of the many different settings that shelter practitioners work in. So I'm going to try and summarise the 6 hours of those shelter and mental health meetings into just a few minutes. For a better picture of what was discussed, please do access the recordings. And again, they're available via the Self-Recovery Project website. Unsurprisingly, we started with that top circle, the one about mental health parameters. And to do that, we reached out to mental health experts. And we're absolutely delighted by the generous response to basically cold calls and cold emails from people to people outside our sector. And today I'm joined again by 2 of the 4 experts who kindly helped us to explore MHPSS a couple of weeks ago. So I'm going to pass straight over to Carmen Valle of IFRC, and I do apologise, Carmen, if I've again pronounced your name incorrectly. And she is the co-chair of the MHPSS reference group, and I think she's probably going to start by explaining what that actually is. I'll pass over to you, Carmen.
Thank you so much, Sue, and hello, everybody. And all the opposite, you always pronounce it so well. I don't think I've ever heard my surname pronounced so well, so thank you for that. And thank you, everybody, for the invitation to the other event, these 2 days that we're summarizing today and today's session, because we are extremely delighted to have more opportunities to exchange with the shelter cluster, precisely for the reasons that Sue has just highlighted. I think the need to understand each other is mutual, and we all are very interested in learning more. So just to continue summarizing what was discussed over these 2 days, I had the opportunity to present briefly what the Interagency Standing Committee reference group for mental health and psychosocial support in emergency settings is. And as you can hear by the name, it is an associated entity of the Interagency Standing Committee, and we coordinate the response on mental health and psychosocial support in all the different settings where it's needed. We provide guidelines, collect good practices, and developed the needed documentation for working in different sectors. We link with different sectors through some of our colleagues and agencies members, and this has been traditionally done more in some sectors than in others, but we are increasingly trying to reach out to maybe sectors with which we have not traditionally worked so much closely, but we already have quite a lot of documentation and technical guidelines on how to integrate MHPSS and mental health and psychosocial support. So this group, this reference group, which is basically is co-chaired at the moment by ourselves, the IFRC Psychosocial Center, and the WHO, is actually a joint effort of all of the agencies that volunteer their work to contribute to the reference group. And since 2007, when the guidelines on mental health and psychosocial support were published, we have been working very strongly in those 3 blocks that you can see in there. I wanted to summarize this just 3 ideas that seemed to be quite important during the event the other day. The first of them is on protecting and advocating for the terminology, because terminology, as we all know, is much more than just the names and the words. And in our case, it's extremely important that we maintain mental health and psychosocial support always together, to acknowledge that if we want to take care of the mental health and well-being of those who are affected by crisis, we have to look at the entire spectrum. And we are not talking about mental illness. That's one part of the entire picture. We're talking about the well-being of communities affected. We're talking about all of the social and psychological aspects of well-being. And of course, yes, we're also talking about mental health conditions that tend to increase and worsen during crises and how to respond to them. But it is indeed the entire continuum, and we always insist that you can't just do one or the other, but you have to act on all of it. And this is why we insist on the MHPSS. Since that moment, since 2007, we've been working in a very coordinated, very joint way. Most agencies use the guidelines as the reference, as the backbone of the work, and then obviously different organizations do different pieces of work. And that backbone is this pyramid that you have in the center of the image, where we've managed to identify what would be the best way to act on mental health and psychosocial support in different levels. It's understanding that the most important, the basis of the pyramid, is making sure that all social considerations in basic services and security are in place, then moving up into community, family support, all of that level of activities that can be done, then moving further up into more specialized services, first with focused psychosocial support, and then the specialized clinical services. This doesn't mean that everybody has to do the entire pyramid, but we have very strong guidance on how to work at all of these levels. And the fact that it's a pyramid indicates that definitely if you work a lot on the bottom of the pyramid, then you need less and less of the top of the clinical services. And that's where many of our colleagues in other sectors have a role to play in that basis of the pyramid. Finally, something that we discussed during the meeting and is very important for our colleagues in other sectors to understand is that precisely because of that continuum and precisely because of the nature of mental health and psychosocial support, we do not sit in any of the traditional clusters of sectors. We are not under health or under protection. We are mainstream and cross-cutting. So we are more and more strongly trying to work with all of these different sectors. Normally at country level, you would find a mental health and psychosocial support technical working group that tries its best to advise and work in collaboration with all of the different sectors. So in that regard, definitely the shelter sector is one of the ones that we want to continue working with. One of the things that echoed a lot the other day, the other couple of days, and that I was really happy to hear from everybody is how we all are aware that the living conditions, the environment in which communities live is really important in affecting mental health and well-being. Just from a very obvious point of view, we all need to live in environments that support our well-being, that makes us feel better, even more when we are going through challenges and emergencies contexts that definitely have an impact on our mental health and well-being. But these daily stressors that we can have, that don't have to do so much with the crisis itself, with these traumatic events, that is a part of what we respond to, but definitely the daily stresses, the social environment and the context is also very important. In that regard, I think we all agreed the other day that shelter is key for people to find a better environment in which they can heal and they can recover, or in which they can continue to thrive better than if the environment is not as supportive mental health and well-being. So I think this is a brief summary of what we discussed at the beginning of the session the other day, and I will pass back to Sue from here.
Thank you so much, Carmen. I think that's a really, really helpful background, of particularly people that weren't with us on that event. That's great. Thank you. And we'll come back to you shortly if we possibly can fit in the time, which I think we will. So just briefly, in the second session of the mental health event a couple of weeks ago, we focused, as Carmen just mentioned, on those living conditions and how people's living conditions affect their physical health. And I think we've all been learning more and more about that recently, but also crucially, how those physical illnesses affect people's mental health, and how, of course, people's mental health also affects their physical health. So all those interactions, I think, are quite hard to unpick, but really important to try to understand. So in order to do that, we had some case studies presented in the session, and we heard from Care Turkey, for example, and Jude from Care Turkey shared reflections about they call them more dignified shelter solutions in northwest Syria, and she told us how people's privacy and safety and security and health and hygiene were improved in these dignified shelters that had been planned in partnership with the IDPs that were living in them. We also heard from Sarah from Archive Global, which is a US-based development not-for-profit organisation, and she talked about their mud to mortar project in Bangladesh, and that was really interesting because that's been running for several years, and improvements to homes, which were initially really intended to improve people's physical health, particularly physical health of children, actually have been seen to have real positive impacts on people's mental health, particularly of women. And then we also heard from Joseph of IOM, and he talked about IOM's various projects to tackle problems of gender-based violence, with the way they did distributions and the setup of settlements, and how really reflecting on the fact that the really good shelter programming can tackle gender-based violence and associated mental health and wellbeing issues as well. And then in the final session of the Mental Health and Learning Day, we reflected on how different shelter and settlement approaches really to programming can have positive impacts on mental health and wellbeing and ultimately support recovery. Miriam from NRC, and also Bill from CARE, and also Katrina from SENDEP added a lot of really useful reflections around that recognition. And good shelter programming already does do so much to support mental health, and perhaps we don't appreciate that or advocate strongly enough for the positive impacts of inclusive and holistic programming. Adequate, safe, healthy shelter is, of course, connected to autonomy and privacy and identity and well-being. So we took those thoughts into the second half day of the learning event on Friday, the 28th of May. And in that session, we really tried to delve more into the centre, that sort of green centre of the diagram, the sort of doing more and doing better bit, really, to look at how those three, the intersections between those three circles really would allow us to think about how we could improve programming where relevant. And so I'm going to pass over to Rebecca Horn now, who is one of the people who helped us in both sessions, both of those mental health sessions. And she's going to revisit the session where she originally did it with Jamie Richardson of CRS. And it was really looking at how good shelter and settlement programming already overlaps with the key principles of MHPSS and with protection. And she suggested some additional next steps for our sector. So I'll pass over to Rebecca.
Thank you, Sue. And thanks for the invitation to join you today. It's great to be part of this meeting. So yes, during the first day, there was a very good question posed in the chat about what is the difference? Is there a difference, in fact, between just good shelter programming and integrating mental health and psychosocial support into shelter programming? I'm a freelance psychosocial specialist, and one of the major pieces of work that I do really is with the ACT Alliance. So through that, I support various ACT Alliance partners who work in different sectors, including shelter, to integrate mental health and psychosocial support into their work. I was really interested just to hear about the work going on with CARD in Malawi, because that was actually one of the organisations I supported a few years ago, working with them to help them integrate mental health and psychosocial support into their flood response. So it would be interesting to know whether they remembered any of that. So what we have in the MHPSS, can I say that? MHPSS field is 6 core principles. And I find these really helpful when we're thinking about good programming and how programming in other sectors can influence positively mental health and psychosocial well-being. And I noticed that Bill has posted in the chat a link to the IASC guidelines on MHPSS in emergencies, and that's where you'll find those core principles described. You can see 4 of them here, and what I'm hoping is that as you're looking at them, you're thinking, well, we do this. This is part of what we already do. And that's true. There's a lot of overlap between these 4 particularly core principles from the MHPSS field and good practice in many of the other sectors in humanitarian settings. So I'm sure that, well, we heard, in fact, during the events that Sue's described to us, we heard really great examples from different parts of the world of how shelter and settlements programming integrates participatory approaches, building on available resources and capacity, looking at how to involve the affected population in the decisions that affect their lives, how to use their skills, their expertise, their understanding of the context to make sure that the programming is effective in that context and meets their needs. Human rights and equity is another core principle from the MHPSS field, but it's something you already do. So reaching out, making sure that you identify those people who are likely to be marginalized and particularly vulnerable in a certain situation, and making sure that their voices are heard and that their needs are met in terms of shelter and settlements. And then we have the 4th core principle here, which of course goes across everything we do in humanitarian settings: do no harm, making sure that we understand the tensions that might exist within a particular context, that we bring people together, that we build connections, that we don't exacerbate tensions, we don't accidentally create problems and create conflict. And we have guidance, as Carmen said, we have guidance on how to do these things within an MHPSS context, but I'm sure that you also, in the shelter and settlement context, have guidance on how to do these things. You're already doing them. So the good news is that already doing these means that you're already integrating MHPSS into many of your programs. If we do these things well, we know that that in itself will promote recovery from distressing experiences, and it will prevent some people, Carmen showed you the pyramid, the triangle, it will prevent some people from developing more severe mental health or emotional problems and requiring specialist services. So anything that you already do that involves bringing people together, promoting social support networks, activating community networks, things like committees to make decisions, committees for implementing certain activities. All of those things in themselves are promoting good mental health and psychosocial well-being. The other thing that you do that we heard about during the sessions the previous weeks is that in the way that you work, you strengthen this feeling of self-efficacy and community efficacy, that despite everything bad that has happened to us, despite all the challenges we face, we still have some capacity for improving our lives. There are some small things we can do that are going to make our lives better. And as much as we can activate that feeling within individuals and within communities, we are promoting good mental health and psychosocial well-being, not only in that moment, but in the longer term. So I hope this is an encouraging message that much of what you're already doing is already integrating MHPSS. Some organisations may feel that we can do a little bit more, and there is in fact more you can do if you have the resources and the capacity. So here we see the pyramid again. Everything you're already doing is strengthening the bottom layer of this pyramid, basic services and security. That's about doing all of those things in ways that strengthen mental health and psychosocial well-being. You're also potentially activating community networks in the way that you provide your services, in the way that you work with communities. So that's our second level also. But always there are going to be in any community a relatively small proportion of the population who do need a little bit more support. And actually the shelter and settlements team are in a great position to do that really, or to support that, because you are out there in the community, you're coming across people who are in all sorts of situations. You're likely to be able to come across people who do need more mental health and psychosocial support services. Often people don't reach out for those themselves, but what you could do is train your staff and your volunteers to recognise the signs of distress, moderate to severe distress. Recognise those signs, know how to interact with people who are distressed. We have simple approaches to that. Psychological first aid is one, and the IASD reference group has just recently produced a great resource around basic psychosocial skills. So knowing how to interact, but also knowing how and where to refer people for more specialist mental health care is also something that shelter staff, shelter volunteers could do. So I think I'll leave it there, Sue. I've got an eye on the time, and I'll hand back to you for the next part.
Thank you so much, Rebecca. That's great. That's a really, really helpful summary of a lot of the things we touched on last time. That's great. Thank you. So for the rest of the mental health learning events, we did use Jamboards to try and capture all the wider participants' ideas. And in addition, of course, we've got the recordings of the breakout room discussions. And there were two main discussion sessions using sort of virtual breakout rooms in these Jamboards. The first session focused broadly on assessments and participatory methods and tools. And the second focused on measuring outcomes of programming and building evidence. Ongoing knowledge and capacity gaps and other challenges were captured in both sessions. So our next step is to create a summary of all the points made by speakers and wider participants over the whole learning event. And this is very much a work in progress. I think we're just going to see a screenshot of my laptop yesterday, which shows that we're really keen to capture all those ideas and summarise them, and to give feedback. So this is very much a work in progress. We're working towards a report of the Shelter and Mental Health meeting, and we will disseminate it once it is complete. And we really hope to involve as many of the speakers and participants in that process. So do get in touch if you've got further thoughts to guide the report. What would practitioners find useful, most importantly? So the panel discussion to follow will no doubt pick up on some of those themes around the contribution of humanitarian shelter to well-being, and also perhaps touch on the challenges of short-term emergency funding when aiming for long-term impacts and steps towards recovery. We learnt at the learning event that our MHPSS experts, for example, Carmen and Rebecca today, for example, via the MHPSS reference group, are keen to work with shelter actors to contribute to well-being of communities affected by crisis, whether those are short-term emergencies or indeed more protracted crises. We're clearly just at the start of a very useful conversation with our MHPSS colleagues. So we are at the time when we're going to move on to the panel discussion. So I'm going to pass over to Ella. And Ella, if perhaps if you have time later, you might want to see if we can bring any further thoughts from Carmen and Rebecca in. But I think it is time to pass over to you. Thank you very much.
Yes, thank you very much, Sue. And it's also very good timekeeping. So I have to make sure that I can do the same. I will try to do my best with the panel discussion now, because we will be very distinguished company. So I'm very humbled to be entrusted with the task of facilitating and moderating this panel. As Sue was already mentioning at the very beginning, at the shelter cluster, we have been looking at the issues of how we can contribute to health and well-being, how we can look at our own work from different angles to of course, gain more traction, but also to see all these potential linkages to increase the impact of our work and improve the services, of course, to the people that we are trying to assist. Obviously, many changes in the focus of the humanitarian sector, as well as the recent crises like COVID, has forced us to think differently. Of course, working in the urban settings, it really pushes us to bring together, to work with different partners, to work across sectors. But also, as we had seen yesterday in the session, negotiating the humanitarian and development spectrum is also forcing us to act like brokers instead of service providers, which is something that we had been doing for a long time. So we have the question of how we, from our side, as shelter and settlement sector, and of course as a global shelter cluster, facilitate, enable, and instigate more cross-sectoral, cross-cluster collaboration. And with this question in mind, and with the ultimate goal of course, improving people's health and well-being, we have a very distinguished panel today, and they will the panelists will help us look to our own work from outside. So we're very used to discussing amongst ourselves what we can do, but of course we don't know what we don't know. So we invited our panelists to help us broaden our thinking, to help us look at our work from outside, and also to deepen our understanding of the connections. So without further ado, I would like to introduce our panelists. And the way I think we will do it is that after the introduction, we will have an initial intervention, about 5 minutes of each. And then we will move into the questions to our panelists. Please also write in the chat if you have any specific questions to any of the panelists, so I can also see how much time we need to dedicate. So I invite everyone to participate in this way. So we will, as you can see from the pictures and the titles, we have a wide variety in our discussion today. I'd like to start with Linda Dowell. She's the Global Health Cluster Coordinator. It's the second time that we have the pleasure of welcoming her in our annual meeting. Last year, she was one of our key speakers at the Ignite session, and she has kindly accepted to be with us again. Linda has been the Global Health Cluster Coordinator since 2014, but she has a very deep understanding and involvement in the cluster system. And she was one of the people who was overseeing the working group that operationalized the transformative agenda. So we interact regularly through the Global Cluster Coordinators group, where she continues to keep us very sharp with her analytical skills and very well-timed critical questions. So we're grateful for her presence. Secondly, I think, Monica, you have joined, you managed to join us on time, but Monica was, she was called into a meeting with the senior management, so we may have to move things around a little bit. Secondly, we're also joined by another global coordinator, Monica Ramos. She's the Global WASH Cluster Coordinator with UNICEF. I'm not going to tell the number of years of experience she has and with how many agencies, because it's really broad experience. And she has also acted in a donor capacity, and in that capacity, actually, the Global Shelter Cluster has worked very closely with Monica when she was with ECHO in the Middle East and when we were managing one of our grants from ECHO. So we have a very pleasant and productive collaboration. So we're very happy to welcome her today in this capacity. Then as our third speaker, we have Cecilia Schmelzer. I have to say that she's an independent consultant, but for me, in my heart, she will be forever linked to the Global Shelter Cluster and the IFRC, because for many years she was our global focal point for technical coordination. So apart from being a fantastic human being, Cecilia is the shelter sector in one person, because she has trained as a carpenter, but while she's a builder, she's also an architect, and she can also plan the settlements around it, while she manages innovation projects and also can give you the evidence about your shelter and settlements programming. So I very much encourage all of you to become good friends with Cecilia, because if you're ever on a remote island, she's one of the people that you would want to take with you to the island for your survival. So we're very happy that she's here with us to represent the shelter angle of our discussion. And of course, last but not least, we are joined by Peter Ventevogel from UNHCR, who's the Senior Mental Health and Psychosocial Support Officer. And he has been in this role since 2013. And his daily job involves providing technical guidance and support to the UNHCR operations. And he has just returned actually from one of these field visits just in time to take part in our panel. And I also had the pleasure to work with Peter during the 2018 revision of the Sphere project, where he was one of the co-leads of the mental health theme. So after this introduction, I would like to give the floor to our panelists for their initial intervention. And I would like to ask all of them in turn to reflect on this question of what you see from your perspective as the most important, but also the most urgent connections between shelter and settlements and achieving physical and mental health and well-being objectives, and especially in the changing humanitarian environment and the various crises that we're facing. So I'd like to start with Linda, if she's ready to go, and we're all ears. Thank you, Linda.
Okay, thanks, Ella, and greetings to everybody. Nice to invite me back for a second time. So as usual, I'm going to posit a few questions. I think what we need to be asking ourselves in terms of health and shelter is, to what extent do our individual cluster sectoral actions, or more importantly, our joint actions, to what extent do they enable or hinder health and well-being? And I'll leave that question there, people can think about it. I think we're quite conversant in a number of areas, particularly around issues of outbreaks. As we know, different disease pathogens have different modes of transmission, and obviously the shelter can play a part in either aiding or reducing transmission, and either also facilitating how the health sector is able to respond to those outbreaks. And I think what COVID did, as we spoke last time, was identify new areas where we had to think about how shelter and health interface to address a respiratory pathogen. But of course, we're well used already of many waterborne pathogens, particularly cholera, where we end up, addressing environmental health issues around both water availability, but also setting up cholera treatment centres, etc. Other environmental health risks, such as smoke, household smoke, and the impact that has on respiratory disease is well known. And again, there's plenty of guidance on this already available. So this is nothing new that I'm saying to you. But what I want to present now is just something I read the other day. It's a rapid agenda analysis that was done by IRC, who's a health cluster partner, and its analysis is just done in Tigray over the last couple of months. And it's pretty sobering and makes us question what it is we're actually doing together on the field. So what they flagged was frequent sexual harassment is happening every single day. Extremely high rates of gender-based violence. Shelters are unsafe for women and girls because of mixed sleeping arrangements and overcrowding. They lacked windows, doors and fencing and easily accessed by intruders. Insufficient wash services. The women would say they're scared to go to toilets. We don't feel safe going to the shower rooms. There's no lights. The darkness scares us. As a consequence, IDPs are defecating there's open defecation. So we're increasing the risk of diarrhea and cholera. Managing menstrual hygiene has become increasingly different because of the lack of strain on water sources, lack of washing facilities, limited sanitary products, leading to indignity, infection risk. Women are evidence of unintended or unattended births in IDP sites and refugee camps because women can't get to health centres. As we know, more than half of health facilities were destroyed deliberately during the conflict, but still we seem not to have put sufficient temporary facilities in place. All of this leads to people living in fear and anxiety, which obviously is part of the mental health discussion, but also living in face of physical harm and the health implications that leads to. So my question to us now is, given that we already have all the guidance available to us, I was looking at SPHERE the other night, I was looking at the MHPSS guidance that's been referenced today, I was looking at some of the environmental, the existing sort of health and shelter guidance. What is it that we are or are not doing that allows us still to be addressing these issues or having to deal with these issues in a conflict in Tigray, which has been going on since last November? So my question is, how do we better use the existing guidance available to us? And how do we have a better conversation, joint conversation, to address these matters? One way to do that may be to look at the work that we have done both with the Health and WASH cluster and also work that we've been doing with the Protection cluster, is coming up with joint operational frameworks, which create the purpose of which is to start identifying entry points for having that strategic and operational collaboration between sectors, improving our integrated approaches to coordination, preparedness and response. These are not prescriptive frameworks, but they're a set of guiding questions that helps us consider how we work better jointly together across the 6 kind of core cluster functions that we have. And I'm happy to come back to that in a bit more detail as part of the panel discussion, but I'll give the floor to other colleagues. Thanks.
Thank you very much, Linda. Already you're animating the discussion and asking, of course, the crucial questions. Thank you so much for that. Monica, if I'm not so sure. Yes, you're there. Okay. I'm very happy that you could join in time. So could you also reflect on the same question as from your perspective, what do you see as the most important and urgent connections, and also maybe building on what Linda has mentioned, if you have any immediate reaction to that. So from WASH, shelter, health, what could be the connections that you see?
Great. Thank you, Ella. Thanks, Linda, for obviously always inspirational words. But I think you know, really for me, it comes down to kind of the core of, you know, dignity. And I think that a lot of what we need to be doing, and particularly the readout, Linda, that you just shared around the dire, you know, situation in Tigray, which we've also been receiving those reports in terms of the WASH and more generally the hygienic living conditions, really comes down to the dignity. And I think that this is really that one word for me, and the definition of it is really where we come together and we intersect across health, shelter and settlements, protection, and beyond. And I think that for me, in terms of the way that we come together, both in the way that we do work as intercluster, but also intersectorial with our partners, should, and I know we strive for this, really be driven around a holistic response. So really breaking down silos of saying, okay, I'm a WASH practitioner, I'm going to come in and deliver a WASH package. We should be looking at it from what is the holistic response that is required, and then what are the necessary capacities and resources and expertise to come in and deliver that holistic package. I think when, you know, spending time in the field, when speaking to those that are affected by the crisis where we are all working, really, you know, people don't see themselves as a sector. They don't see themselves as having needs. You know, we do this kind of mathematical calculation where we hear something say, oh, they need WASH, they need help, they need this, but it's not that. You know, we need to really understand what it takes to ensure that we are meeting the minimum standards, as Linda said, because the standards are there. I mean, I think we have evolved so much as a humanitarian community to have really well-defined standards, really well-defined metrics. But it's true, we're still missing the mark. And I think part of it is really how much we can really put ourselves in the role of those that are in need of the assistance that we do provide. And I think also really maybe not the right way of putting it, but you know, this holistic response for me is really about making it less transactional, making it less about output based. You know, we installed X amount of latrines, but really what has that then resulted in? Do young women and girls and even young boys and men feel safe using those latrines? Are we seeing less open defecation as a result of that? And so I think we do really need to shift, all of us, our approach from this kind of results driven to a more outcome approach, and really asking, and many of you, I know I see familiar faces here, in my time as a donor, you know, we'd go on these visits and then I see everything and I'd say, so what is ultimately this all, you know, the impact of all of this? Are we seeing, you know, less disease because people are using the hand washing stations effectively, or we are seeing less open defecation? Are we really having an impact in the lives of those that we are meant to be? And I think that it is a little bit of a taking a step back, rethinking our fit for purpose. And I think this conversation is one of those first steps towards that. How do we come together under a platform or in some sort of initiative? And like Linda was mentioning, we've done some joint work around cholera with the Global Health Cluster. We're also doing some joint work with nutrition and also with the food security clusters around the issue of famine. But how do we come together around these thematic issues of urban displacement, conflict, environmental? I think we haven't seen the beginning of the impact of climate and the environmental issues that will be coming in years, as well, public health emergencies, and what is the holistic package that can come together, and what can we all contribute to that? So we have been involved in a variety of conversations over the past few weeks. We've been coming to different meetings and hosting different side events where we really are trying to shift the dialogue, and what we kind of always title it is breaking the silos. We are very committed to doing that, and we're really looking at where WASH, both from a coordination point of view, but also our partners working with us both at the global, regional, and country level are able to help plug into a response and provide that to be more outcome focused and also, you know, timely, predictable with high quality. So I think for me, those are kind of the points, but really with that mind of the dignity aspect. I mean, we have to really think about those that are affected on the ground and really put ourselves in their situation and really think about how we would would want services to be delivered to us and assistance to be delivered to us. Make it a little bit less transactional, a little bit less output focused. I know we still need the metrics, we still need to measure what we do, but I think we may have lost a little bit of sight of that human touch. Over. Thanks, Ella.
Thank you very much, Monica. That your intervention has made me immediately think of a conversation that we had yesterday with another partner, innovation partner, who had told us that us humanitarians are very focused on solutions, and we don't define the objective or the result, the ideal situation. We just define the in-between steps, and as such, maybe we try to control the process too much, and not so much the desired outcome, in which you have given the name of dignity in this case. And it's still, I do agree that it's something that we need to take a step back and step out of our usual frameworks and work differently. So let's unpack that in the coming questions. But I'd like to now ask Peter to see if what he sees as the most important and urgent connections between our fields, which is for us a slightly newer aspect of exploration. So going deeper into mental and psychosocial well-being, what would be your initial thoughts to share with us, Peter?
Thank you very much. Can you hear me, Ella?
Yes, loud and clear.
Perfect. So thank you very much. It's a pleasure to be here. What I would like to do is to share a few pictures that could illustrate my story. Is that okay?
Of course, go ahead.
So I'm doing it. So you should, if I'm right, you should. It's coming now.
Yes.
Yes. So let me start with some thoughts then, because I do really not have that much to add to what Carmen and Rebecca already have said, because I'm very much on the same line with them, and that's also because all of us are, let's say, pioneers of MHPSS, if I may say so, because it's a relatively new field and traditionally also quite a close-knit community, although it's growing quite expansively, fortunately, in the last few years. So I think the things that were said, I fully endorse. And one thing I want to bring forward is that Linda mentioned the issue of the sectors or the sectoral boundaries, do they help or hinder the delivery of a holistic response? And I think there is a lot to say about that. Well, one thing about MHPSS is that it is consciously not defined as a new additional sector or subsector of something else, because there was no buy-in for that in 2007. But I think it's also a smart choice, because that means that it is you can call it a cross-sectoral issue, but you can also call it a multi-sectoral issue, an issue in which all the sectors need to act. And that's how I actually like to see it. Now, and then the links between shelter and settlement and mental health and psychosocial well-being have actually been, I think, relatively ignored. We work quite closely with some other clusters and sectors, but not so much with shelter and settlement. And that actually is a pity. And I just want to show you a picture. I went to Gedaref state in Sudan, where you have the Tigray emergency, and there were actually two major camps. This is one of them. This is Tunaydba camp, where I went first. Bloody hot, I may say, and in the midst of a semi-desert, I would say. And the shelter officer who was there and the camp management, they were really happy with this camp, because this is actually an ideal camp and it looks good from a shelter perspective. And I actually only thought, like, oh my God, what if you live here? I mean, it doesn't feel like a place where you can live. It looks a bit like these pictures from the Roman camps in the Asterix and Obelix strips. but it doesn't look like a place where you can actually have a community. Then the second day I went to this camp. Horrible, according to my shelter colleagues. And I think every one of you can see that there are houses really in the wrong places, and the raining season is coming. So there are really real dangers here. But I'm not a shelter expert, obviously, so I didn't even see those things. I looked at how the community was organized, and I looked more or less at the social infrastructure, and I thought, this is much better, because I saw shops, I saw some communal spaces, I saw people in the street, and you can see the setup of this place is much more how a spontaneously developed African village would look. And indeed, this was the first of the two camps, and this was largely self-settlement. The refugees were there really before the humanitarian response really got full traction. So people did things that they thought were logic. People would move together when they wanted to be together. And in doing that, they made some technically wrong choices, perhaps, but I found it interesting to see how I felt these differences. Now, partially that is also because of the stage in the emergency. Rakuba is a little bit the older camp, 2 months, but that's a significant difference in an acute emergency. And we know that the levels of distress and the levels of mental health issues change over time. In an acute setting, you have massive distress, and then when things calm down and people can go on with their lives, it becomes less, unless it becomes really a protracted setting, and then it gets more. So I usually use 3 slides when I teach students in MHPSS, and I was looking at them again, and I thought actually there is they have a lot to do with shelter. Because the first picture I always show is this one from 1994, the Rwandans fleeing to DRC. And I always ask, how do you think their psychosocial well-being is? And of course, people here are worried about their daily needs. Where will I sleep? Where will I find food? So here, the lack of basic necessities is really the issue. But then let's move forward to this camp, which is in Rwanda. But here we have actually people from Burundi moving into Rwanda. This is a camp of around 6 months old. And you can imagine here that the most basic protection and survival risks have been addressed. There is water, there is food, there is maybe a health center, so it's there. But what actually is the task here, the developmental task, I would almost say, of the refugee community, is to become a community again. Because this again doesn't look like an African village, it looks like an artificial place. And the task here is to bring people together and to help people help themselves. And when you do that, many people will be able to go on. But in these houses, maybe 1 in 10, there will be someone with a more severe depression or a severe post-traumatic stress issue who is not able to cope. So those are the ones that we actually want to target with more focused MHPSS support. And then let's move forward to a typical protracted setting. And again, I was struck by the fact that how much shelter actually says it all, because there is no person to be seen on this picture. This is the old Rohingya camp before the current emergency. And I think you all know this was very much a protracted setting, and even a policy of verelendung, where actually due to decisions by government and the humanitarian, no, not the humanitarian, I think really the government, that the camps couldn't grow and couldn't thrive. And the idea really was people shouldn't thrive. So you see here cramped housing conditions. And you can imagine here that if you have to live here for decades, it's not good for your mental health. So those were the things that I just wanted to share. And I wanted to say, if I looked at the shelter chapter in the Sphere Handbook, and actually the things I like to highlight are already mentioned here about a sense of safety, sense of belonging, sense of social cohesion. So let me move forward. I think the pyramid I don't have to explain because Carmen did that very nicely. But I want to show you one other thing. This is from a document that the Global Protection Cluster recently issued together with the IESC reference group. And we actually wanted to show here that MHPSS is not a sector, but it's something that is linked to the existing sectors and clusters. And you see a nice image here, and we took care to not forget camp coordination and camp management and not forget education. But hey, we should have put shelter and settlement here, and we didn't. So that's, I think, an illustration of how easy these links tend to be perhaps overlooked, or we think like, yeah, we know all that. Now, my last slide then is what are things that we could do jointly, and this is very much non-exhaustive. I think, yes, using participatory and inclusive approaches in S&S are important, but I think maybe we can actually sit together and see how people with an MHPSS background and people with a shelter background can actually work together and see how to do that, because I see it not routinely being done in emergencies. Then what Rebecca already mentioned, I think some of the most clear first responders are people working in shelter and settlement. They're in the field, they're not in offices. And so they interact with people who are our beneficiaries. So I think they need to be trained in how to deal with people who are acutely distressed, who are difficult, who are angry or withdrawn. And we have techniques for that, but we hardly reach out. We reach out to protection, to education, but not so much to S&S. Then when it comes to space, I think the houses are important, the tents, but of course also what is in between those individual houses. So the establishment of communal spaces and open areas in camps is so important for psychosocial well-being. And then the last points are more related to people with severe mental health conditions. One thing that always frustrates me is how much we have to fight for extra space, extra tents, extra shelter for families who have a person with a severe mental health condition in their midst, because really social support also needs space, so to say. And lastly, then, when we are, that's very specific, but when we're building health facilities, it's always important to have good private consultation spaces, but even more so for MHPSS. So I think we need to think about that. And of course, also when we say we want to have some beds in a general health facility for people with mental health conditions, that's what we advocate for. And we say this needs to be done in the general ward, which I agree with. We don't want separate mental hospitals or whatever, but it would be happy if we would have some places where there could be some privacy, because it's really difficult to have a person with psychosis in a general hospital ward. So it also needs physical space. That's all I wanted to say. Thank you very much.
Thank you very much, Peter. You had said that you're not so well versed in shelter and settlements, and I think you were just being very humble, because you have highlighted some of the age-old dilemmas of urban design and planning dilemmas and different schools. And of course, you have highlighted the fact that building physical structures does not necessarily build communities. And actually, I really liked your point of how you can actually manipulate space not to make people thrive and have go on with their recovery process, and just to stall them in that perpetual emergency state. So that's also something to pick up on. And you already also covered some of the questions that I was going to ask you. So we'll get back to you in a little while with some more specific ones. But I want to now ask Cecilia how she sees the same question from inside. So looking out from shelter and settlements perspective. Do you also agree with the connections that were mentioned, or when you were joining, you had a completely different set of speaking points, and now you have to just see if we have to look at things differently? So how does it look from your angle, Cecilia? for a couple of minutes before we go into the discussion.
Yeah. Well, thank you very much, Ella, for this introduction. And I feel a bit intimidated by Ella's introduction, I have to admit, because I have very big shoes to fill now suddenly. But I was very inspired by all the inputs from the colleagues before me, and I completely changed all of my speaking points. So maybe I'll have to take it a bit more randomly now, because it really, I mean, I agree with a lot of things, and I think there's nobody challenging the fact that there is an extreme important connection between the quality of housing or shelter in that case. And for shelter, it's maybe even more relevant than for housing on people's physical and health, mental health and well-being. So I think that is something we all agree on. However, and this has been mentioned by, I think, all of the three speakers before me, it's really, really complicated and difficult to achieve even the minimum standards when we talk about shelter and settlements. It's really hard. And just maybe to catch on Peter's most recent intervention, I mean, town planning and settlement planning, that's a process that usually takes like centuries even. I mean, not just a few months. And we try to do that within even a few weeks. So that's impossible. And I think we have to acknowledge that. But and also shelter has really tended to be very much oriented or influenced by the logistics of it, just because it deals with so much, just so much things that have to be procured, that have to be transported, that have to be set up, that have to be built. I mean, there's a lot of effort and capacities and resources going into that. And all of that during a very short time frame. Nevertheless, of course, I think there's a whole lot of room of improvement, for then looking at the longer term, because we do know that a lot of the crises are protected and we don't have to leave the camp in the state that it is when it is first set up, but it can actually move, and especially because we have like more temporary shelters, and that actually is something I think that would be really interesting to explore further than and to take it that step forward to actually rather talk about settlements than camps, and to make it more participatory, which in the beginning is impossible because people aren't there when the camp is set up, so they can't participate, at least in many situations. But I'd also like to point out some other aspects, and I think, like, talking from the point of view of a shelter practitioner, I think we've been really largely ignorant of the impact that our interventions actually have on people's health. It's not something that has been the focus of our attention, and especially for those of us who work more in post-natural disaster contexts. I mean, we've really tended to focus very much on the structural weaknesses of the buildings that had failed because of that disaster, and to then improve on those and to make sure people rebuild stronger and more resistant to potential future disasters. And because of that focus, I think we've really lost the scope that actually the casualties, I mean, if you really go to that point, the casualties caused by natural disasters are by far not as high as casualties caused, for example, by indoor air pollution. There's absolutely, I think it's like, on average, I had looked up some numbers, 10,000 deaths more or less attributed to natural disasters per year, and that might vary largely depending on the disasters. But there's an estimated 1.6 million deaths that are related to indoor air pollution caused by smoke and open fires in badly ventilated spaces because people are cooking inside, and that affects mainly children and women, of course. And we've really not been that much aware of it, or not putting enough attention on that. So I think in terms of our shelter practitioners, we really need to refocus a bit and start to understand a bit better where we need to focus if really we want to save lives and improve people's living conditions. And maybe that's not the hurricane straps and the deep foundations that we've been trying to promote and that we've put a lot of effort into, but maybe it's really refocusing on other issues. Also the issue of space. I mean, we do have evidence that providing better space and separation and privacy, I mean, apart from the whole dignity discussion, it really does decrease the transmission of diseases. It also decreases the domestic violence. And the same is true on the settlement scale. If the spaces are better distributed, and there's studies from cities, from urban areas, where improving public spaces has absolutely helped to decrease vandalism and violence in those areas. So I think we can all learn from that. it's just, I think for us, what is really important is to understand which of those interventions have the highest impact and which ones we should prioritize, because very often, or probably most of the time, we find ourselves in the situation where we just can't do all of it, or at least not all at once. So if we can sort of understand which ones are the priority interventions that we need to do first, and then take it there step by step, incrementally improving, and then adding another piece and another piece, but that would be really good to understand. So how we can really, over time, improve on those interventions that we do. And for that, I mean, obviously, I mean, we need to collaborate on it, and I think that's really, I'm really happy about this connection that we're now making. I was extremely frustrated in my last shelter cluster coordination position in Mozambique a bit more than a year ago, when we were supposed to contribute to the COVID-19 appeal, and in the global appeal shelter wasn't even included and in the first round of it. So I think that's really something we need to be more aware of, and reciprocally become more aware of, like, that really there is something to be learned from each other, and there's something that we can really also get out of each other, and obviously the people that we serve will have high benefits if we manage to better connect shelter and health interventions, and to see what we do. I mean, from shelter practitioner side, to see our shelter interventions also much more from this health lens. Yeah, and I think I might stop with that because I'm aware of time. I think, yeah, let's leave it at that.
Thank you, Cecilia, also for reminding us that once we save lives, or once the communities save each other's lives, we also have to make sure that we don't kill the people by not providing the right circumstances for it. So thank you for that. I'm also mindful of the time, but I wanted to ask a question to both Linda and Monica. So whoever wants to go first can, the other one can have a think.
Oh, okay.
So my question is, if you had a magic lamp, and the lamp has to be called shelter, so you get a shelter genie, I'd like to hear from you. What would be your 3 wishes, either to remove some of the barriers, or to have more guidance, or whatever? What would be your, so in other words, what would be your wishes from us to reach the dignity, to not have reports like what Linda has been reading to us, and obviously has been touching us, all of us in the session very much, and it's a very serious condition. So I can't offer you another type of genie, but if you had the shelter one, what would be the 3 wishes? Who wants to go first? Maybe Monica. I'll because we always think WASH and shelter are kindred spirits. I don't know if the feeling is mutual, but I will then first start with you while Linda gets to have a think about her wishes.
Great. No, and we are. And thanks so much, Ella. So I think my first wish is just this open dialogue. I think I spent so much time, particularly in the Middle East, where we are very much kindred spirits, Ella, across shelter, settlements, and WASH, covering both of those sectors, and seeing, you know, even on a very micro level, those touch points of conversations just were not happening. You know, a kind of a stock taking of, okay, so what is your programming approach? What are your partners doing? This is what my partners are doing. Great. Where do we come together? And sometimes people say, no, but after the front door, it's shelter, and after, you know, before the front door, it's WASH. Well, no, you know, we need to break these type of silos, because the idea is really, yes, exactly, safe, dignified living conditions, which does obviously involve the WASH. So first, that open dialogue, and kind of that it becomes the way of working. I think particularly when we are something I also would have experienced as a practitioner is you do kind of hear that, you know, a settlement or a camp is being set up, and you're like, well, why haven't we really been consulted? So again, that talking to each other, having that joint planning, that joint needs assessment approach, I think would be really my second wish. And then I think my third wish is really just to have kind of an integrated package that we could really agree upon, and we could really say that, you know, this is kind of the minimum based off of the standards and the metrics that we do have that we would expect to see in different types of responses. And really, I think I always talk about the idea of really taking it from a thematic approach and not so much a sectorial approach. So what are we going to do in a post-emergency crisis, as Cecilia was talking about? What is that package? What are we going to do in an urban setting, conflict, displacement? What are we going to do, you know, in different settings? And I think that that's something that already Linda and myself, we've been working on with some of the other clusters and sectors to try to come across, you know, what is really that kind of joint operational framework? What are the minimum things that need to happen to make sure that the programming is as holistic and integrated as possible? So three, a lot more communicating, a lot more talking to each other, and a lot more jointness. We're all part of one big team. So really kind of with that spirit. Over.
Great, thank you. How about you, Linda?
Thanks. Yeah, well, you know, I'm with Monica, but I think yeah, go Health and Wash. Look, I think the big thing that has come out of the work that we've done both with WASH and the conversations, the work we've done with the protection cluster on these joint operational frameworks is we think we speak the same language, but we don't. Yeah. So again, it comes down to connecting, making these conversations happen. And sometimes to make these conversations happen, it's beholden on our respective genies here at global level to send a message to our respective colleagues to say, we're committed to making this conversation happen. Then, of course, it's how do we, you know, what are they talking about? Now, I've put in the chat box just very top level outline of what these joint operational frameworks try to do. But the very first element is to have a basic understanding of what is our perception of risk. So what are the public health situational analysis, which of course will change over time. You know, there's what's happening in the acute event, but it changes over time. And then how is shelter perceiving risk? And where do you come together and bring those analyses together and say, okay, so if this is our mutual understanding of what risk is, then that, I mean, I hate to say it, this is the JIAF scenario, but I mean, this kind of helps us then basically help understand what are the risks, who's most at risk, how do we prioritize populations, how do we program geographically, but then importantly thematically, and as Monica already says, what does an integrated package look like in respect of the required response? And that conversation needs to happen over time. But the biggest problem, and Monica's already said it, is people don't come together to have that conversation. And then even if they do have the initial conversation, they don't continue to share the information. But as we know within the humanitarian community right now, this push is to have these multi-sectorial conversation, and it starts with the needs, the risk identification, needs analysis, needs assessment, risk analysis, prioritization and targeting. So we need to, and the spaces are already there, we just need to use them. But we need to, at the global level, this is how we need to facilitate people to have these conversations. And it's not always about endless rigid tools, but it's about questions to help our colleagues have the conversation. And then many of the tools and stuff are already there. We can see it in the guidance that we have. But how do they then bring that into the support their conversations? So if your genie can do that, they're welcome.
Yes, we will. We're hearing you for sure, and we will try to at least do our part. So I think we might need a few genies coming together. But okay, I have so many questions obviously to ask to you, but we will not have all that time. I just wanted to ask Peter, because you have already given us a good list of where we could start. I wanted to ask you if you also experience that you also would have the same wishes. And then I want to ask Cecilia from your side what you think as the main needs for advocacy, joint advocacy, before we wrap up with maybe, I don't know if we will have time for a couple of questions from the audience, with a few words on concrete next steps. So Peter, you don't get to do 3 wishes, you just have 1.
No, I just agree with what has been said. And the thing is, what I'm not even have a wish because I agree, but I just want to say we should change our way of thinking, and perhaps one of the best MHPSS interventions could actually be a shelter intervention. That's the way we should think, and that could perhaps be. And then if we think in that way, we get a little bit out of these artificial borders in between our sectors. So that's the only thing I want to say.
And I fully agree with that. And Cecilia, how about how we would market or advocate for this? How could the one be a good intervention for the other one?
Yeah, I mean, obviously, joint conversation is probably what we need first, and I'd say on all levels. Like, let's start on global level with a good example, but that needs to happen on all country cluster levels, and also amongst agencies, like really on NGO level. And why don't they team up together? I think we have quite a practice of having shelter agencies team up with more WASH-related agencies, like in the field, and really complementing their programming. And the same could happen with the shelter and WASH agencies, I would think. In terms of advocacy points, very concretely, I think what we need first is really maybe a bit, or maybe it exists and I'm not aware of it, like just more evidence of what are the key interventions. As I said, like just putting in that chimney, if that saves 1.6 million lives per year, that's really worth doing it. And that's a good argument also towards donors. Whereas, and the same maybe with space, I mean, if providing that many square meters, and I mean, maybe that's because shelter is very technical and we are engineers and architects, most of us, we want these numbers, but it also helps to convince donors. I mean, if you can say, okay, that 1 square meter of more space per person equals so many % less women, you know, being harassed, or I mean, that's very difficult connections to make, I'm aware, but maybe we can find others that are more easy to prove. I mean, the chimney is probably one of the more evident and easy ones. But we had during those the health days that Suzanne was mentioning, there was this nice example of the concrete mortar floor that was put in, and that reduced the prevalence of diarrheal diseases by 77%. I mean, that's huge. And that little bit of cement that was put in, I mean, in terms of cost, I think that's something that we can really easily advocate for if we have these kind of numbers to prove the impact. So I would really advocate for collecting evidence together. And I think we would really also need that health expertise in order to even know how to collect that evidence properly, because as shelter practitioners, we were not really, you know, we wouldn't even know how to do that well. And and also with the assessments, I mean, how to integrate those health related questions into our assessments, etc. So I think that would be really useful conversations that we can have, and with big impacts, hopefully, like really in the field, on the ground.
Yes, thanks so much. And sometimes I think, in my experience, sometimes doing things at a global level might be a bit more daunting, and some country clusters could also be a very good example of how people, when the global people are not looking that way, can actually do fantastic joint work. So I think there's so much to learn from our country clusters in that sense. I want to see if there's like one burning question from the audience. I don't know. I haven't been able to follow the chat so well. Something that we haven't covered. Now is the time to unmute and start speaking. Any questions?
Hi, this is Pablo. Perhaps a question. I don't know. I've seen Alex on the call. There are some interventions in shelter that may be considered more developmental or recovery oriented, but that actually have a huge impact on health. And I've just seen the Sue just posted paint, or what you just talked about, Cecilia. I guess, I'm not sure it's a question, but we need a bit of joint advocacy with donors sometimes to prioritize interventions that might not strictly fall within the very narrow definition of saving lives or humanitarian, but might have huge longer term impacts. And maybe just a reflection, not necessarily a question. Thanks.
Yes, thank you, Pablo, for that point. It's also very valid, and I think it strengthens the message that Cecilia was also making before. Like, once the lives are saved, under which conditions people are living, also linking up with what Peter was showing. So there is a lot of work for all of us to do, I think. But just to wrap up, I picked up a lot of ideas and also different ways of doing it. So what Linda was saying, yes, what we can improve together is one way of looking at it, but also what is hindering us is also another way of looking at our maybe joint objectives together. So dignity as the beacon towards which we all should go, and a holistic package, and most importantly, dialogue and the language. So we might be having a dialogue and think that we understand each other, but maybe we do need the simultaneous translation in between. And I did hear the very concrete suggestion. Actually, it was a suggestion from our side that's been floating around for a long time, to have maybe an intercluster working group to look at these issues. But what Linda has suggested as the joint operational framework could be a more manageable first step. I don't know if everyone would agree, but I think that from the chat I can see that it caught on quite a lot. So I hope we can make some steps to really work on that. We can piggyback on what's existing with health, wash, and protection, and add the shelter lens. So we would definitely be reaching out to you. And the second concrete one is to our colleagues who are in the thematic subgroup for the MHPSS. Please also add shelter into that diagram and tell us how we can also support that. So with that, I think I will bring this session to a close. So I hope this was a first or a second step in establishing that dialogue. You have been very inspirational in your interventions. So thank you very much, all of you. You will be very warmly welcomed within the shelter cluster, and we will definitely also be reaching out to you with some of our ideas. You can tell us that they don't make any sense, and come back with some other ideas. But we really would like to work on evidence, to work on advocacy, and to really work on the programming together, regardless of the labels. So with that, I'd like to thank everyone, all of our panelists, for taking the time to be here in their very, very busy schedules. It meant a lot to us. And I also would like to tell our audience that the annual meeting is continuing, of course, with our networking and sessions. And we have our working group presentations in actually about an hour's time. And tomorrow we're going to have our big Ignite panel. Linda was part of it last year. This year we're looking at the topic of shelter and settlements in a changing environment, where we will be looking at humanitarian trends and the environmental aspects of our work. So please join us to hear from another very interesting set of panelists. So thank you very much, and have a good rest of the day.